Hello, this is Muriel. I work for the International Osteoporosis Foundation. I'm the science coordinator for the Capture the Fracture program. And welcome to this webinar on GetMap, how to get the best practice recognition for your FLS. It's my pleasure to introduce you to Dr. Kassim Javed, who's the co-chair of the program, and will show you how to sign up to the program and understand all the best practice framework, the core document we have on this program. Just before I start, please, if you have any questions during this webinar, type them into the question box and we will voice them for you at any time during this webinar or after. And please enjoy it. Over to you, Kassim.
Good morning, everyone. My name is Kassim Javed. I'm an academic rheumatologist from Oxford, and I'm delighted to share with you how to get mapped using the IOF Capture the Fracture Best Practice Framework tool. Next slide. The main objectives for this webinar are to understand how to apply the program, complete the questionnaire, and use this to set up the most effective FLS in your region. You will also understand the key principles on how to implement an FLS and be aware of the wealth of other tools available to support you to do this. When we look at how to implement a successful FLS, there are four broad stages. The first is to achieve political prioritization, have the policy statements in place to support you applying for and getting funded for an FLS. Once the political statements are in place, the next stage is to write the business plan, business proposal, or application form to get funded. Once funded, the key is to get started and use the tools available to learn from the mistakes of others so you get the best start possible for your FLS. The final stage is probably the most important. This is continual improvement of your FLS so it becomes self-sustaining and is not vulnerable to defunding. The rationale for an FLS has been covered by the two previous webinars, and I'll just review this briefly. We know there are many millions of fragility fractures, one every 3 seconds across the world. And yet we know 80% at least of patients who have fragility fracture receive inadequate clinical care and are not screened or treated. This leads to many avoidable fractures with impacts not only on the patient, but also their family, the local healthcare, social care, and national economic status. And it's estimated the direct costs will exceed 110 billion per year in the EU, US, and China by 2025. Why has this care gap remained? The reason is it's very hard to close. To achieve the aim of having an effective FLS that reduces refractures, leads to fewer secondary care admissions and fewer care home admissions, and produces savings to the healthcare organisation, requires effective implementation of 4 steps. The first is to identify those patients at risk. The next is to make sure every single patient receives the same standard of investigation and risk assessment to identify those at highest risk requiring therapy. The second stage is to make sure that we tailor both the bone and falls prevention therapy to the patient, so the patient starts on the most effective treatments at the beginning. And the final stage is to monitor, not only for ongoing treatment adherence for both falls and bones interventions, but also for continuing refractures and falls that may require changes in treatment strategy. It's very clear that there are many FLSs present in the world and they have very different structures. And the key question we have to ask is every FLS once it's set up automatically effective? From the previous slide you've seen there are key questions to be asked, and it's unlikely to be effective unless each of these steps is adequately addressed. And this was the main purpose of the best practice framework. It is to set clear criteria and standards to measure an FLS to support its effective implementation. It will provide audits to allow services to be benchmarked, but also, more importantly, to receive feedback on areas where they can improve to become sustainable. So to recap, the 4 challenges of the care gap are firstly identification. This may be challenging. How does one case find and identify those with cognitive impairment or dementia? They may present in a number of outpatient settings, not only in the trauma setting. They also may present in other wards, such as the general medical ward for pelvic and spine fractures. The most challenging group for identification are vertebral fractures. Despite the increasing number of patients undergoing cross-sectional imaging with CT or MRI, very few of them have active case finding for serendipitous vertebral fractures, even though we know these are still predictive of recurrent fracture. The next stage is investigation. The numbers are large and require systems in place to ensure each patient has the most effective and efficient assessment program, which can include questionnaires, blood tests, and DEXA. We care for a very frail population. Some of our patients have mobility issues or cognitive impairment, and therefore any investigative pathway must be minimally disruptive, with as few as possible extra hospital or clinic visits, extra blood tests, or investigations. The next step is to match the treatment for bone and falls health to the patient. We now have a range of bone therapies, and in addition to funding implications, we must also look at comorbidities to help us guide the most appropriate treatment to start patients on. The final stage is monitoring. We know adherence to pharmacotherapy and falls interventions is poor, and we need to not only identify these patients, but also act on the findings we find. This may include extra visits, changes in pharmacotherapy using different modes of administration, or re-review in clinic. It's also important to look for side effects, and if there's another fracture or fall, it's important to identify these because this may result in a treatment change or a treatment escalation. To address all of these complex issues, we have applied 13 standards or criteria for fracture liaison services across 5 domains. I'll now go through each of the 13 standards and then go through the 5 domains later. The first standard is patient identification. Each criteria is divided into a bronze, silver, and gold standard. And for patient identification, bronze is that patients are identified, but there's no system for tracking within the hospital system. Silver is for when they're identified and there's a separate tracking system. And the gold standard, which is aspirational, is that not only do you have a standard process for finding these patients, but you regularly independently review this either through spot audits or an external body to pick up the patients that may have been missed. We understand from the most successful FLSs in the globe, most have more than one strategy for case identification. The second standard relates to the proportion of patients who are evaluated for future fracture risk, and they're divided into bronze 50%, silver 70%, and gold 90%. The third standard relates to the timing of the assessment, whether it's within 16 weeks, 12 weeks, or within 8 weeks for bronze, silver, and gold. We understood that vertebral fractures were a challenging group for case identification, so we created a separate standard for these patients. Bronze is where the patient presents to the healthcare system because of their fracture, either to a spine clinic or to another clinic. And bronze is for those patients to be included into the FLS. Silver are systems where vertebral fracture assessment or lateral spine radiography is routinely carried out in patients already identified at high risk of fracture, such as the time of DEXA. Gold is the aspiration, and that is where there's a system in place where radiologists or other healthcare providers can screen images from patients who have not been identified at high risk of fracture for serendipitous vertebral fractures, and these can then be fed into the fracture liaison system. The fifth standard relates to the quality of the assessment, and whether it's in line with local, regional, or national guidelines. The sixth standard relates to testing for secondary causes of osteoporosis, primarily through blood tests. Bronze is where 50% of patients are screened, silver where 70% are screened, and gold where 90% are screened. We recognise that to prevent fractures requires not only bone assessment but also falls assessment. So Standard 7 addresses this in the proportion of patients who are assessed for falls risk and then sent for prevention as required. Bronze 50, silver 70%, and gold 90%. We also recognise the importance of lifestyle factors, including diet, smoking, and alcohol intake. And Standard 8 refers to the proportion of patients who are screened and referred for lifestyle changes. Bronze again 50%, silver 70%, and gold 90%. Standard 9 refers to those patients who are recommended treatment who are actually initiated on treatment. And again, we use the same threshold of 50, 70, and 90%. We recognise that many patients have already been identified at high risk of fracture at the time they've had a fracture and may already be on pharmacotherapy. Standard 10 emphasises the need to reassess for compliance and other risk factors that may cause them to fracture on treatment. And again, we use thresholds of 50, 70, and 90% for bronze, silver, and gold. We recognise the care of hip fracture liaison patients as being multidisciplinary, and Standard 11 ensures that the recommendations are communicated to the physicians and what proportion of the criteria set of data are included. And here we can see the criteria set may include FRAX, DEXA, primary and secondary risk factors, falls risk, current medications and medication compliance, the follow-up plan, lifestyle changes, and time since last fracture. The final two standards relate to long-term follow-up and IT infrastructure. Standard 12 is the only standard that has two, criteria 12 is the only criteria that has two standards. For bronze, the follow-up is only arranged at greater than a year. For gold, there is both short and long-term follow-up, so within a year and beyond a year. And finally, for Standard 13, is how the fragility fractures are recorded, whether they're recorded in a local, regional, or national database. Clearly, some of these national databases are out of reach at the local level, but should provide an impetus for the provision of national databases. The National Hip Fracture Database has clearly shown how a national approach to hip fracture care can reduce morbidity and improve the quality of care. The process for applying for the mapping on the FLS map for the capture of fracture are in 4 stages. The first stage is the participant completes the online application. Once the application is received by the IOF, your site will be marked on green with a green star on the map while it's being reviewed. We recognise we're using one tool to assess healthcare delivered across a global basis with many local, national and regional variations. So expect to have quite an extensive dialogue and communication for clarification with the office and the IOF, which consists of administrators, researchers and also clinicians. Once the final score has been discussed and agreed with both the site and also with the IOF CTF clinical scientific advisors, your score will be recorded on the map as a colour and a number.
Kasim, sorry
Yes.
to interrupt. We have a question about the Standard 1. It
Yes.
says, can you explain more about what the tracking requirements is? patient identification is very clear, but I do not understand what is needed. Track a patient.
Okay, so tracking is a system in place in your hospital where you can follow the patient through. So for example, you may have an electronic medical record system, you may have a database in your orthopedic clinic that can track the patients. Other private HMOs also have tracking systems, and it's really comparing a paper-based system with an electronic or other system where you can, for example, examine outpatient lists or ward lists on an electronic system. Does that answer the question?
I guess yes. Otherwise, please,
Okay.
Anne, feel free to ask again more questions if this is not clear. Thank you, Kasim.
Not at all. So for the scoring, it's across 5 domains. We've chosen these domains because they each require different types of case identification. The first domain are the hip fracture patients. The second domain are other inpatients who don't have hip fractures. The third domains are patients who are only managed in the outpatient setting. The fourth domain are the vertebral fracture patients who aren't captured in the above 3 domains. And the fourth domain are the organizational score, which combines both the falls services and also the database requirements. Why have we set up this process? There are 2 broad objectives. One is from the service user. We are committed to improving the delivery of secondary fracture prevention globally, and we hope by using the best practice tariff and the toolkits we can drive improvement and recognize excellence, so we can have as many sites within as many countries operating at the Gold 5 standard. Equally as important, patients are becoming more empowered and questioning the quality of the care they receive at their local hospital. Uniquely, this allows patients from anywhere in the world to look up their own hospital to check the quality of the care that they receive. This is very encouraging. The patient voice is increasingly recognized by payers as an important component of changing practice. And by combining both the service provider and the patient voice provides a very compelling argument for case improvement. So in Oxford, in the hospital I work in, we are very good for hip, inpatient and outpatient fractures, but only bronze or vertebral fractures. So a patient who has a scan and has an incidental or serendipitous vertebral fracture will not be found in our hospital. And we have used this information together with the patient voice to now apply for extra funding to improve case finding for these patients. The Best Practice Framework Questionnaire is now available in 3 languages, and there are detailed guidelines on how you complete the application, and also a glossary of terms defining what an FLS is, a site is, a fragility fracture, inpatient stay, clinical, radiological, vertebral fractures, and what constitutes a service review. The questionnaires provide us a PDF that you complete and includes a number of sections. Section A gives us information about your hospital. Section B tells us who's completing this form and how we can contact them for clarification. Section C tells us who's leading the service. And Section D allows us to understand who's actually delivering the fracture liaison secondary fracture prevention pathway locally. E is about the resourcing of your service. How much clinician, nurse, and other healthcare professional time is included in your service. F is really devoted to the identification, how each type of patient is identified and using which methods. G is about, once they're identified, who assesses a patient and who is eligible for DEXA and also the type of blood tests that are used. We then go into, by domain, what proportion of patients are identified, evaluated, and at which time points. And then, as I mentioned before, for the vertebral fracture, we apply these separately for clinical vertebral fractures, fractures identified using DEXA or lateral vertebral radiology, and then separately for systematic screening of other cross-sectional imaging to identify patients with silent vertebral fractures. Then we fill in the section on assessment guidelines and how they've been developed and which, if any, risk-calculated tool you use. We're very interested in how different sites assess patients for secondary causes of osteoporosis. And we now ask for not only the proportion, but what blood tests you routinely include. We have a section in the end section on the full services, whether this is included within your service, if not, who offers it, and are there any restrictions that apply. The O section relates to the multifaceted health and lifestyle risk factor assessment, and the section P is about what proportion are initiated on treatment, and section Q, the proportion that have a medication review if they fracture on treatment. Section R relates to the communication strategy in terms of who gets the information and what information is included in the report. Section S is the most challenging section, and this is about long-term management. What does it include? And then in section 3 onwards, S3 onwards, which patients are included and at what time points. Finally, section T relates to the database and IT infrastructure for your service. Once the questionnaire is completed, and it can be saved and resaved and adjusted as needed, we suggest you send the questionnaire and rename it with your site name, here it's Oxford FLS, and the year, to capture the fracture at iofbonehealth.org. We're committed to making the completion of the questionnaire as straightforward and as simple as possible. So we would value you also spending just 5 minutes completing the FLS questionnaire available on this site so we can continue to include improvements to the questionnaire design. And we usually redesign the questionnaire every 2 years. As you may know, we now have a competition available, and that one survey respondent will receive free registration to the next World Conference in Malaga in 2016. However, the questionnaire is only part of a large number of tools we have to help you develop and implement an effective FLS. As well as a large number of papers available in our anthology, we have published papers specifically related to this program, looking at a nice paper by David Marsh looking at the rationale for FLS, Christina Ackerson introducing the fracture prevention pathway with Capture the Fracture and the Best Practice Framework, and then a paper we published earlier this year looking at the first results from using this framework. We also have available over 70 slides that you can freely use if you have to present the FLS case to other members in your clinical team, to payers and other providers. We also have worked hard to deliver a toolkit. We understand many physicians are very busy and have limited time to spend, collate and reference business cases for their FLS. As I've already said, the framework has been translated into English, Japanese and German, and we're waiting for 2 other languages, and the framework is available in the languages you can see. On the website, we also have information about success stories, and this is very important. So if you're in a country, you can go on the map, see which other countries have successful FLSs. You can go in the success stories section and get information in more detail about the sort of service and the sort of hurdles they had to face. And we're supporting this in our next webinar, which is tackling this directly looking at success stories in Singapore and in the UK. We also have information about local audits and surveys in the resources section of the website. And I'd just like to thank the other members of the CTF Steering Committee who have been instrumental in getting us to this stage. Without them, we would not have been able to develop the framework, the standards, the questionnaire, and the implementation program. I'd also like to thank our sponsors, Amgen, UCB, Lilly, MSD and Servier for supporting this program of work, without whom also we would have been unable to deliver it to the standard that we have. Our vision is that by implementing a global FLS with standards that ensure what is put in place is effective, we will truly be able to offer patients an opportunity to stop at one, to make their first break their last. And I'm now happy to receive any questions. Thank you very much for your time.
Thank you very much, Kasim, for this very clear overview of the best practice framework and its standards and the program Capture the Fracture. We can now take any question you have on this presentation. I'll start with one. How do you take into account some countries who cannot afford some drugs, such as differences in reimbursement?
That is a very important question, and it has come up in some cases. We are very fortunate that most of the oral bisphosphonates are now generic and cost less than $15 or 12 euros a year. So the price of our first-line medications are coming down. That is why we have not specifically addressed the type of medication that can be used. This is a very important point to bring up when we talk about the conversation that takes place after submission and before awarding the STAR. And we would welcome any comments from the applicants on this.
Thank you, Kasim. Another question is, are there many FLS in the private sector? Is there any advice you would offer to secure funding for private programs?
This is a very important question. We have come across this many times. There are two aspects to this. Number one is the holistic approach. Many private providers are only focused on one part of the care pathway sometimes, and so may not realize the benefits of having an effective secondary fracture prevention, but may have to bear the costs. And this often requires private providers to work in collaboration, which is the new model of care. We always take the argument back to the patient. What is best for the patient? Clearly the private providers have other needs as well, but we hope that providing a framework by which they can work together will support this. If the private provider only sees a subsection of patients, for example, only outpatients or inpatients, we will not expect them to be graded in the other domains. So we will not expect them to, we will not mark them down for not having a domain score in hip, vertebral, and inpatients if all they see are clinic patients.
Thank you, Kasim. What would be the most difficult part in setting up an FLS, based on your experience?
The most difficult part is where you are on the 4 steps. So if you have no political prioritization, it's very hard. This often requires a local champion working, finding adjunctive funding from other sources to set up a service. However, we now have compelling economic data that setting up a fracture liaison service is cost-saving for the healthcare system as a whole. And with this argument, should make political prioritization easier. The more you invest, the more will be saved. I think the next hurdle is getting funded, and in the toolkit we actually have template business cases where you can insert your country and your own data in pre-filled out texts that have all the references included. So you don't have to worry about reviewing literature, it's already been done for you, and then work out the economic evaluation. Setting up a service is challenging. It requires communication across many domains, and that's where using the success stories and the local audits and data is very helpful, and also using the mentoring package in the CTF. And the final is improvement, and it requires humility to understand that actually the service you put in to start with may not be the best one to work with your local healthcare program and be always ready to change and adapt to changing needs.
Another question from Alberto asking, is there any criteria about communicating results? He means by reduction of fractures, adherence to treatment, etc. Does it include in the communication strategy criteria?
No, we don't include that in the communication strategy criteria. The communication is really based around communication of the FLS assessment and investigation to the treatment initiation. It's a very important question, how do we assess the effect and impact of the fracture liaison service? While refracture is an important and probably the most important clinical endpoint, it's very hard to find this out at a regional level when ages are increasing, frailty is increasing, and actually what we're trying to do is to stop the increase in hip fractures and other fractures and slow this increase down. If we had to pick one criteria to judge the success of your service, it will be the proportion who are on effective therapy 1 year after their fracture. That seems to be the most reliable and robust measure of treatment and impact. We assume that if the patients are still on treatment by 1 year, they're highly likely to continue treatment, as most of the non-adherence happens in the first 3 to 6 months.
Susan is asking, do you have many FLS who prescribe for patients versus those who rely on GP prescribers?
That's a very good question. We have few, but where they are present, we're evaluating them. Clearly, the link is actually to make sure the patient gets a repeat prescription. And there is a risk if you give it straight away that all that will happen is the patient will use up the amount they've been given in the FLS clinic and that it's not communicated to the GP. The benefit is the patient is immediately initiated on therapy and can relate taking the drug to their risk of fracture. So we have two competing priorities here, and time will tell which of these is most successful in ensuring adherence at 12 months. From preliminary data, giving the patient a packet of drug at the time of their assessment leads to about a 70% adherence at 1 year, which is very high.
Kasim, how many people have filled the questionnaire so far?
I will pass that back to Muriel. She knows it way better than I do. Muriel, what are we up to now?
We have about 128 questionnaire filled. I think you must have a slide showing the map of best practice, yes, where you can see all the different FLS that are already on our network, and 77 have already a grade of either silver, bronze, or gold achievement, and we've got 51 either waiting for more data or currently under review for evaluation. And this brings to another question, which is, what happens if I do not have an FLS yet? Can I still fill the questionnaire?
Yes, we would strongly encourage you to complete the questionnaire for 2 reasons. One, it will be very easy because the questions will have very simple answers. And 2, it will give you a lever to go to your payer to say, I'm on the map and I can't get scored because I haven't got a good service. And you could also then direct your patients to it and inactivate the patient voice. We would like, our aspiration is that every hospital setting or primary healthcare setting that sees fragility fracture patients is on the map, either as unscorable or bronze, silver and gold. We'll put you on as a white star, indicating that you do not have a service in place, but that it's coming. And we hope by using the white star approach, we can really empower you and give you the motivation to and support you to get your FLS funded and started.
Looking at all the 13 criteria, we understand that some of them are aspirational and others are essential. Which are the ones that are essential to have an effective FLS or to start with?
I think the key approach is identification, investigation, treatment initiation. You have to be able to identify within a domain a large number of patients. If you're identifying less than 50 patients within the domain, it's difficult to score. And that's the key aim. Once you've found them, I think the next most important thing is to make sure they're investigated and then monitored. I would suggest a system is gold in one domain rather than bronze across all four, because by being gold in one domain will get you a gold star. And actually what that will force your site to do is develop a pathway that crosses all four steps of a successful FLS. And then it's relatively easy to actually increase the flow rate. Whereas if you focus on just identifying all the patients, you still require structural changes to include investigation, treatment initiation, and monitoring.
Thank you very much, Kasim. If you have any additional questions, please ask them now. I'll ask one last question, which is, what are the most difficult sections to fill in the questionnaire, you would say?
Yeah, I think the most difficult section that we have trouble with is the long-term adherence and follow-up. That's the one that's very challenging. It has been something that has been not the focus of the original set of FLSs. The original FLS set up in Glasgow and other sites was really focused on identification, investigation, and treatment recommendation, and left monitoring for adherence and refracture to the primary care physician or general practitioner. We now know this is not sufficient to deliver an effective FLS because the rates of non-adherence are very high. In the old days, there was very little choice we had in pharmacotherapy. We now have drug treatments we can give to patients potentially who do not adhere, either by subcutaneous or intravenous injection, to improve adherence. And because of that, we've included adherence as part of the FLS structure.
Thank you very much, Kasim. I think we've done all the questions. So I would like to thank all the participants to have attended this webinar. I hope it has met all your expectations. Thank you very much, Kasim, for this excellent webinar on the best practice framework and the program. And stay tuned for the next webinar, which will be in November on the 19th for success stories. If you have time, please send us the survey, fill the survey so we have some feedback and we know how you think about it and how to improve our webinars. Thank you very much. Bye-bye.
Bye-bye.